evening, everybody, and welcome to the November Conversations with a Doc. We are extraordinarily lucky this evening to have two absolutely terrific people, Rebecca Rye, or Becky, a psychiatric nurse, practitioner, right? Yeah,
Mhm.
I got mouthful. And Gwenn Smith, who is the Richmond Professor of Psychiatry, both from Hopkins. And I think we're in for just a great session this evening. Some of you have submitted questions. If others of you have questions, just feel free to go into the chat and ask them, and we'll get them all answered. And the other thing, which we haven't done for a few weeks, but I am asking everybody again, when we're going to send out an evaluation at the end of this, and please, please, please fill it out. It takes less than 5 minutes. And in order for us to keep offering these things, we really do need feedback from all of you. So please do that. And with that, I'm going to turn it over to Becky.
Okay, thank you for the introduction. Good evening, everyone. Again, my name is Rebecca Rye, and I'm going to speak to you this evening about the non-motor symptoms of Parkinson's, specifically psychiatric non-motor symptoms. So I'm going to share my screen. And okay, so we'll first start with depression. There are several different non-motor symptoms of psychiatric symptoms. So I'd like to talk about depression first, and then we'll discuss anxiety symptoms, and then apathy. So when we talk about depression, of course, usually people describe that as a feeling of sadness or unhappiness or feeling blue. And we have to remember that sadness is a normal experience. It's a normal human emotion. But when we're talking about this in the context of a neurologic disease, major depression is often part of the picture. And when we're talking about major depression, this takes on a different tone. So we have changes in mood, and you'll also have changes in your well-being or vital sense. That's what we mean by that. Ability to feel good about yourself, to experience pleasure in things. And then there is a category with how depression affects physical symptoms, somatic symptoms. So this means changes in sleep or appetite, concentration, and energy. So I want to just mention briefly, just coping with the diagnosis of Parkinson's can be a difficult and can produce a lot of emotions. And it's normal to have mood changes after the initial diagnosis, and it's a time to really absorb what is happening. But we'll speak here in a minute for how long those symptoms persist. So usually when we're talking about Parkinson's disease, the diagnosis is based on evidence of a movement disorder. But as I said, I don't want to, we're finding out more about the non-motor symptoms of Parkinson's disease and how much they are part of the total picture. And as I said, we're talking about depression. We can talk about anxiety, sleep disturbances, impulse control disorders, cognitive changes. All of these things can go under that category. And what's important to note is that we've really found that if we don't treat the depression, it can get in the way of long-term adverse events with Parkinson's, how you're managing your Parkinson's and your daily functioning. So, of course, we want to prioritize this. And the good news is that depression is treatable. So let's go over the signs and symptoms of depression. I mentioned a few before, but you can have sadness. Some people don't have sadness. Some people actually experience depression as an inability to enjoy things. So it could be either or both. Often energy is affected. There's a lot of anxiety and worry, and that can go along with depressive symptoms. There's a feeling, sometimes you can have a feeling of hopelessness about the future. It can affect your self-esteem, and you feel bad about yourself. You can start to have these negative self-talk, negative excessive feelings of guilt, and just sort of feeling bad or worthless. Depression can affect your appetite. It can affect sleep and either impair your ability to sleep effectively or actually sleep too much. It can affect your libido or sex drive. And then more severely, when you're having thought, it can cause someone to have thoughts about dying or wishing they were dead, or even suicidal thoughts. So when we're thinking about these things, when to ask for help. Now, as I said in the beginning, normal sadness is a normal human emotion, but when these symptoms or combination of symptoms continue daily and are really persist for more than 2 weeks, that would be a time to ask for help. And certainly bringing up, if you're not already in treatment, bringing that up with a primary care doctor or your neurologist would be certainly the next step. If someone has lost weight without explanation, that's also another good reason to bring that observation up with your primary care doctor or neurologist. And then, of course, anytime someone's having thoughts of suicide or death, would certainly ask for help, seek treatment. So when we're talking about treatment of depression, if you've had a thorough medical and psychiatric evaluation, you always want to start with your medical or neurologist, medical provider or neurologist. And what we usually do is rule out any other causes that could be medical causes or anything that could be contributing to what the symptoms are that you're feeling. You want to, of course, see your neurologist and be sure that your motor symptoms in your Parkinson's disease are adequately treated. And then once we've ruled out everything else, and we have this constellation of symptoms, then if there's a diagnosis of depression, we provide treatment, either pharmacologic and non-pharmacologic. So the best treatment is usually a combination of both. Pharmacology or medication management, and then psychotherapy, whether it's in the form of supportive therapy or cognitive behavioral therapy. The best evidence is the combination of medication and cognitive behavioral therapy. But not to be left out, of course, is a healthy exercise regimen. Regular exercise can be very effective for treating depression and anxiety. Maintaining a healthy diet, maintaining a good structured daytime routine, and good sleep hygiene at night. All of that plays a part in maintaining mental health. Of course, seeking treatment depending on where you are in the stage of Parkinson's disease, getting physical therapy if necessary, occupational therapy not to be left out, and speech therapy. And then accessing the large amount of support network in Parkinson's community, educating yourself and your family about Parkinson's disease, and tapping into that local and national support network. When we're talking about pharmacologic treatment, I'm not going to go in detail about these, but these are some medications that you may hear about or see. So just to familiarize yourself, of course, the first category of antidepressants that usually are tried to treat depression is an SSRI, or serotonin selective reuptake inhibitor. That's just basically how that medication works, but very common Lexapro or Zoloft, citalopram, typical in the category. There are others, but these are probably more commonly used. SNRIs is the next category, that serotonin norepinephrine reuptake inhibitors, and the two in this category are venlafaxine or duloxetine, very effective also for treatment of depression. You will see mirtazapine, which is kind of in a category a little bit on its own, but very effective for anxiety and also has good properties for combination. So there's, and then tricyclic antidepressants, the tried and true nortriptyline. You will see sometimes dopamine agonists, which your neurologist may use more often, but pramipexole has been shown to actually help some depressive symptoms, and then occasionally an MAOI inhibitor. So just so you familiarize yourself with the names. And then non-pharmacologic treatment, this is just as important. So establishing a therapeutic relationship with your psychiatric provider is really important. Supportive therapy, of course, initially, and then cognitive behavioral therapy can be very effective for helping a lot of the anxiety symptoms associated with the depression and also depressive symptoms. Understanding relaxation strategies, practicing them, developing your toolbox to use when you're applying the cognitive behavioral techniques. Mindfulness-based therapy can be very effective for relaxation response. Again, I'm going to repeat exercise here, so it's that important. And then, of course, diet and proper hygiene. So combining all of these things and juggling the different symptoms from, and then the different strategies for treating depression can be hard to do that all on your own. So having somebody to be able to, a therapist or a psychiatrist, to be able to bat that against, is this more in the neurologic realm? Is this more in my psychiatric realm? What am I dealing with here? Can be very helpful strategy. So anxiety in Parkinson's disease. So you can have anxiety as part of your depressive syndrome and a presentation, or you can really have generalized anxiety symptoms. And this means, or panic symptoms. And this includes just generalized worry throughout the day, or excessive worry, or feeling restless, or anxiety can kind of amplify your motor symptoms. If it's so you might see that your tremor increases in states of anxiety. It can cause sleep disturbance, fatigue. It really can impair your ability to concentrate. When someone's anxiety is up so high, you're just not absorbing information as you should. It's often difficult to recognize in Parkinson's because often because the motor symptoms are often affected by anxiety. Sometimes it's easy to say, well, my levodopa dose needs to be adjusted. And maybe it does, but also the anxiety could be exacerbating it. And of course, the anxiety piece and the depression piece is likely also due to the same degenerative process that is going on with the Parkinson's disease. So treatment for anxiety is often very similar to treatment for depression. So we would start with an SSRI if we're talking about pharmacologic management. Backing up a minute, again, the same with depression. You want to make sure that your motor symptoms are as adequately treated as possible. Treat the co-occurring depression because that actually might resolve your depressive symptom, the anxiety symptoms. Exercise, again, I'm going to be a broken record. And then pharmacotherapy, we can use some other agents, or we often do use other agents in addition to antidepressants to get a better handle with the anxiety. And this might include medicines like quetiapine or gabapentin, or even a benzodiazepine at times. And then, of course, cognitive behavioral therapy, as we discussed. So that's the same structured framework as we would have for depression. actually, I'll back up a minute here. I do want to mention, so relaxation training in cognitive behavioral therapy, that's really important routine to probably establish early on. And that would include things like deep breathing or mindfulness techniques or meditation. And to get into regular practice with that, I would encourage that, if possible, to do as regular as your exercise routine. It can be very helpful when you've had practice at it, and when you're in a situation where you're more anxious, or if you're having freezing or something like that, you're familiar with the techniques, you've had some practice, and it might be more helpful. And then just to mention about apathy. This is a trickier one. Apathy is really a state, it's defined as a state of decreased motivation. And whether that is teasing out, whether that's related to depression, or is it related to a cognitive change, or is it really just a part of the non-motor symptom of Parkinson's disease, is difficult. It's really thought to be related to the same neuronal loss that occurs in Parkinson's disease. Probably before, I should add something to this slide, before we even think about medication management for apathy, defining it is the hardest part, and identifying it. And then also, how would you manage it pharmacologically? And this goes across the board for everybody, to have a structured day, and to really have some goals that you're going to meet each day, and you might push yourself to get to them, but to have that plan in place is probably one of our best ways to treat that. To have, this is not open areas of unscheduled time are probably not your friend in this section. So I would try to think about some type of outside activity each day, and follow a regular scheduled program. That would be really helpful for managing medications, managing your exercise regimen, and then trying to address this apathy. But of the medications that we found, rivastigmine, or a cholinesterase inhibitor, has been excuse me, shown to be effective for treatment of apathy and Parkinson's. And sometimes the dopamine agonists also can be helpful, but really making sure you're strict with establishing a structured routine could be very helpful. And I was going to stop there, actually. I don't think we need to go into the neurobiology of it, but so I'll stop.
Okay, so Gwen, do you want to go next? And then we'll do questions at the end. Can't hear you.
Oh.
Unmute.
Oh, I think I'm unmuted now. Sorry about that. You would think after all of these months of so let me I always have a very cluttered desktop. So here we go. Great. So so what I thought I would do after Becky's sort of comprehensive talk, and I just wanted to include a couple of slides and give us plenty of time for discussion. And I wanted to really sort of kind of emphasize, as the title indicates, the importance of treating depression. So I have to say, my in terms of my own work, and I'm actually strictly a researcher, and I'm really fortunate to be have the opportunity to work with really outstanding clinicians who, like Becky and my other colleagues, who really inspire the research questions that let me see, let me put this here we go, that inspired the research questions, and really over the years, you know, I always tell the story. I started my career in research working in Alzheimer's disease, and I worked alongside movement disorders neurologists who inspired work that I've done in Parkinson's. And it was only, really in sort of the middle of my career when I worked as part of a center for depression and focusing on depression that occurs later in life, to that I really understood the really substantial role that depression has in the aging process, and also the superimposition of depression on a lot of conditions that we treat, and especially Parkinson's disease. And one of when I was early in the course of this research, I visited Johns Hopkins, and I met Laura Marsh, who was one of the founders of our Parkinson's psychiatry program. And I was, saying to Laura, well, is there something, do you think there's really something biological in depression? Is there really something there that, do you recommend, continuing this as a focus? And Laura was one of the investigators in one of the major clinical trials of antidepressants in Parkinson's. And, Laura was very encouraging of this area. And Laura, I remember she made the comment to me, and there was, I think, some evidence, I don't know how strong it is at this point, but Laura was saying, we've just done this study, and we find that if we take two groups of individuals with Parkinson's disease, both who have depression, and in one case the patients are treated with antidepressant medication and their symptoms are well managed, and in the other group the symptoms are not as well, are untreated and not managed. And she said, and in the patients who are adequately treated, we actually see that there's not only less severe motor symptoms, but less progression over time. And I think that's still, that's an observation where there's some evidence, and it's a bit controversial, but I was really struck by that. This was, now when I think about this was about a couple of decades ago when I met Laura. And then, so that really, that, and then some of the data that I'll refer to in a couple of slides really kind of, reinforce the first of all, the treatment of depression, but also understanding the biology of depression. And the idea is that if we understand the biological mechanisms, not only can we maybe, improve the course of illness, but we might even be able to have some information about early diagnosis. So I'll just go over, and there's a lot of evidence for this, but I just wanted to kind of summarize the main conclusions that depression, in a whole host of studies looking at the relationship between depression and subsequent cognitive decline, so things like memory and executive function, there's really a substantial evidence for depression in later life being associated with these sort of cognitive problems, and even going further, that the evidence really points to the fact that an episode of depression in late life maybe is associated with increased risk not only of Alzheimer's disease but vascular dementia. So the two main areas where there is a role for of substantial cognitive decline, and in this case, and we know there's a lot of heterogeneity in the literature. We've shown that the vascular symptoms are related to depression, and as I'll show in a minute, even some of the pathology we see in Alzheimer's disease is associated with depression as well. The other kind of large body of evidence that was really striking to me, and that kind of persists till this day, is the fact that in the presence of a whole host of medical conditions, that the earliest data came from studies of patients with cardiac illness and patients recovering from MIs from heart attacks and all, that not only are individuals with depression at greater risk for cardiac events, but if someone is depressed, the recovery from a cardiac event is actually recovery is impaired by having a concurrent depression. And then similarly, we have a lot of evidence that even, things like surgeries, orthopedic surgery, knee replacement, even the condition called postoperative delirium and postoperative cognitive decline, the side effects that some individuals get from anesthesia may be worsened with a concurrent depression. And then the final point that I'll make that is really, again, kind of a general principle that we've observed in a lot of studies is that actually it's been shown in Parkinson's disease, Alzheimer's disease, and other neurological conditions that depression may actually be the earliest sign. A change in mood may be a sign of subsequent, motor problems, cognitive problems, and again, the idea that if we understood would focus on these symptoms, study them, and understand the biology, maybe we can prevent the even disease progression. So this is something, again, it's one of these areas where we have there's been a lot of work that's been done, and I think it's still an open question because these are very kind of difficult studies to do. We can't really do I always say to our volunteers in our research that when we identify someone who has depression, we want to start treatment yesterday. So we don't certainly want to, in this circumstance, compare a placebo certainly to an active medication. So there's some challenges, but we actually looking at big data sets. One of my colleagues at Johns Hopkins, who's a biostatistician, Jeannie Leosakos, has actually come up with ways of looking at large data and addressing this question: does treatment of depression prevent cognitive decline? So that's something that we're hoping that she'll have some answers for us pretty soon. So this is just a couple of examples from work that I've done over the years. So this is a map of the brain. It's an MRI scan, and people who know me, they know that if I'm giving a talk, there has to be a brain. That's at least one brain slide. So I only have two of them. So here, what this shows is it's the structural image of the brain, and what we've done is we've done a PET scan of glucose metabolism in the brain, and glucose metabolism. Glucose is the main fuel for the brain. Glucose, and when we measure it in different brain regions, is very closely tied to neuronal activity of nerve cells, neurons, and brain energy. And in this image, what we showed, and we've actually seen this in several different groups of people, is when we compare depressed patients to a control group who's not depressed but the same age and gender matched and all, that in depression the brain is working harder, the energy metabolism is higher, and what happens is the energy metabolism is actually, the rate of metabolism is higher in areas that show low metabolism in Alzheimer's. So what we've thought about is that what is going on is that the brain is really trying to compensate for perhaps for different neurodegenerative changes that are occurring, and the higher metabolism may not be, may be a sign of pathology. So that's one of the observations we've made. And another example from our work, this is again an MRI, but we superimposed the different PET data on the scans. On the left panel, we have the amyloid protein. So amyloid is one of the main proteins that occurs in Alzheimer's disease. And in this study, we looked at individuals with depression, and we looked to see if they have more of this amyloid protein, again, to try to understand why is it that depression is related to cognitive decline. Is depression an early sign? So what we did see is we saw an increase in amyloid in the brain in this group of patients. And then what we did was we looked at whether this increase in the amyloid protein is associated with a change in a brain chemical that's related to depression. And here we've looked at a chemical called serotonin, which is the target of many of the antidepressants that are prescribed. And what we saw was this association between higher levels of this protein and lower levels of serotonin. And low serotonin is one of the major findings in depression research, and which is why the antidepressants are given to raise serotonin. And if we compare this to what we see in individuals with early Alzheimer's, in that circumstance, this represents a bit less of the pathology, but it's some support for the fact that if we look at individuals with depression and we study them carefully, and this is a study where we did memory testing in all the individuals, if we look very carefully, we might be able to find pathology that can be a target of treatment. And then the last point I'll make is along the lines of the importance of studying depression is that this is an article from a newspaper from New York, the Long Island Newsday, and it's now a couple of decades old, and it's an article that was published by our research group, and we were interested, as we always are, in recruiting volunteers, and a local science writer, Jamie Talon, who's actually become very famous, not because of this article, but since, and so we talked to her about writing this article. So we have my great colleague Elise Kramer, one of my favorite people, great neuropsychologist, Greg Henriksen, who is Greg does a lot of work with psychotherapy for late life depression. And the gentleman who is standing up with a big smile is Harold Terrens. So Mr. Terrens was a volunteer in our study, and this was in, let me see, so this was 2004, exactly. So that was 20 years ago, and he responded to an ad for a study, for a treatment study where we did brain imaging, and he had a great outcome with the study. In fact, he and I used to go to senior centers in the Long Island area to talk to people about research, and he's just an incredible person. And we sort of stayed in touch, and then I moved to, I came to Baltimore and all, and we lost touch a bit. And about 2 years ago, I got a phone message from Mr. Terrens, and he reminded me, and when I actually did the math, so he was 81 when we did this. He volunteered for the study, and he was about to turn 100 years old. And he told me, which is my colleagues like Becky hear this all the time about how they treat patients, but it's rare for a researcher to get a phone call and say, "Your study changed my life." And he said, we could discuss his, symptoms and all, but he was really feeling, had really the symptoms of depression. They were very, very disruptive, and he responded very well to the medication and really enjoyed participating in research. So he reminded me that he was turning 100 years old, and he and I have talked about, he wants to come to Baltimore for a PET scan. So we're trying to figure out how to do that, and or maybe to do some of the other testing to see how his memory is doing. And what was really exciting was in June of this year, and this will be my last slide. Some of you may have heard about this. So Mr. Terrens actually was involved in the Battle of Normandy and would go back to France every few years. He received the Order of France a couple of years ago, and this year he actually remarried. So his wife, who remember was just a wonderful person, his first wife, a professor of French, and we discussed, he and I, that she had Alzheimer's disease and passed away, and then he moved to Florida, and then met his current wife. So he just got married in Normandy, and it was there was a dinner that night with the Emmanuel Macron and with President Biden, and it was very exciting. So that was a big event. But he still kind of when we've had conversations since, really talks about the impact of depression treatment. So that's what I thought I would leave everyone with, is that just it's really important. There's been a lot of discussion over the last few years about depression and anxiety and approaches to mental health. And one thing that Becky has really been at the forefront of is coming up with innovative treatments, including non-pharmacologic treatments for depression, anxiety that we can talk about during the discussion. So I'm going to stop here, and I really look forward to questions.
Okay, Michael, do you have to unmute me or can I unmute myself?
I think you
Okay,
are.
I think I did it.
Yep,
Or
you
I
are good to
unmuted
go.
you. I unmuted you. Sorry. Okay, here are some of the questions. The first one is, please discuss natural and herbal remedies for the treatment of PD, anxiety, and depression.
Well, let's see. So I don't know that I can discuss herbal remedies or natural. So from if they're talking about pharmacologic natural, or I would certainly reinforce the exercise piece if we're talking about that, but they're asking for a specific herbal remedy.
Natural and herbal remedies.
I think
I guess somebody might be thinking about St. John's wort, for instance.
Right. So I would be very careful about St. John's wort, actually. So it can have a lot of drug-drug interactions, and I would steer clear of that. It's nicer to, I think it's better to take something that we know what the drug-drug interactions are going to be with. So something that's prescribed, we already, but we can't always predict that with some of the herbal over the counter. And the other piece about herbal remedies is they're not regulated like the regular medications are. So we can't always know exactly what's in that preparation like we would for a regular antidepressant.
So before somebody decided to take something like that, like a gummy or something, they should check with their movement disorder specialist.
Absolutely, that, or their primary care or psychiatrist. Yeah.
Okay, next question.
And I think,
sorry.
Sorry.
I was going to make
Gwen.
one comment. I think, Becky, correct me if I'm wrong, but with the different cannabis preparations, we don't know a lot about them. So
yes, correct.
There are a lot of basic questions, and there are a lot of we have at Hopkins a big research unit that is, and a number of colleagues who study or are looking at these things and characterizing the different compounds. And when I've asked them about different metabolites that have come up in analyses we've done, they will say to me, well, we just don't know what the effects of this particular metabolite is, not the main compound, but how when the drug is processed. So I think with those compounds, I screen a lot of people on for memory problems, and many people will describe different memory problems they have, and then later on when we talk about I specifically now ask about supplements, and many of these individuals will be taking using gummies and all, and there may be great benefits, but I think you have to be careful. So I don't know what your opinion is, but as a PhD, that's what I would say.
I would totally agree with you, Gwen. I think that it's sort of the cart before the horse. We don't know a lot of the benefits yet. So,
Okay, next question. My husband's anxiety influences many no answers to things I want to do. For example, having friends to dinner and making changes to the house. If I go ahead and do things after he has made it clear that he disapproves, then I feel guilty and he gets mad. That sounds familiar.
that does.
If I cast my mind back far enough, I feel like I do not have any say about our life. It's very frustrating. Is there any medication that could help him be more flexible?
So I think, when we're talking about anxiety, well, first we need to see where, a good evaluation to see where some of his concerns lie. But it sounded like she was thinking that I'm guessing he might be more anxious and that he's saying no before he gets to whatever the event is. One of the things that's pretty common for Parkinson, there's different types of anxiety, and you've probably heard about, there's the performance anxiety where you're getting up and talking in front of a lot of people. It's specific to Parkinson's is a lot of anticipatory anxiety where they're worrying about situations that they might get into. And in order to decrease the anxiety, they'll just say, no, I'm not going to go, or cancel, or just not. And then that automatically does the trick, except that it then in the long run affects your quality of life. You're missing out on lots of social things. You're missing out on changes or challenges or new experiences. And we want to try to, avoid that. So there might be, I'm guessing that's where some of this is from, but it might be more than that. So we need,
So God knows I'm no psychiatrist, but
yeah.
but I'm wondering if anger couldn't be in there too. I mean, it seems to me that people
Absolutely.
could be very angry with the diagnosis, and depending on where they are in that could be part of all this too, couldn't it?
Absolutely, yes, and that they just don't want to participate or engage socially for a while. Is that, I'm sure. So we need more information, I think, about where his no is coming from, maybe.
Okay, and okay, so then here's a question that may sort of fit in with that. How does somebody get evaluated to see if they are suffering from anxiety or depression? Some doctors give a questionnaire to rate feelings between 1 and 10, but I feel you can answer those any way you think the doctor wants. So I don't think it doesn't feel like a true evaluation.
I actually would agree with that person. I think that the tools of maybe they're referring to are screening tools. That if they get a positive answer from a screening tool for depression or a screening for anxiety, that should then prompt them to get bumped up to a formal evaluation. So it's really not a diagnosis. It's more a screening tool that says, oh, yep, okay, so maybe this person does have some more there, and let's send them and refer them on for a formal evaluation. And then depending on where they are, you would want to try to get referred to a psychiatrist who has some experience with Parkinson's disease, because I think that's helpful to understand the interplay between the motor symptoms and psychiatric symptoms. They can be hard to tease out. But starting either with their primary care, they'll see those screening tools a lot in the primary care office or the neurologist's office. And then usually if they screen positive, then they'll be referred to our clinic, or, so depending on where, is everyone here in Maryland, or could this be?
No, it can be anywhere.
Anyway,
I think most of them are from Maryland, but not all.
Okay.
It's open to the world. But
Oh, okay.
I think most of them are in this country, at least, I think.
Okay.
Oh my God. Here's a question that just came in on the chat. What's the value of CBD in treating Parkinson's and anxiety?
I can't, Gwen, I can't speak to that actually. So I don't know.
And do you have any insights?
CBD?
Yeah.
Or CBD. That's enough.
I think they said
CBD. Cannabis.
Yes,
Yeah,
CBD.
exactly. Yeah. So I think that, I mean, it's one of these situations where I think it's, there is, to my knowledge, data from animal models, from mice and rats, but I don't know if there's a lot of evidence from, from humans about supporting this. And I think there's been, a bit of caution in terms of doing, I'm not aware of sort of formal studies, but which, may still be happening, but I think we don't really have an answer at this point. I think it's not been studied thoroughly.
So would that be the same kind of answer that you gave earlier, which is think about that kind of thing in, with, caution and check with your.
Oh,
primary care.
absolutely, yes,
Mhm.
exactly. And I think you have to, you know, with, as with, anything, even the supplements, you really have to consult with your doctor and see what their opinion is about this.
Here's another one. Hello. I would like to find a naturopathic doctor who treats Parkinson's in Maryland. I found one in New Hampshire, but does such a doctor exist in Maryland? And then I wouldn't have to travel.
I don't know the answer to that. I would say,
I don't either.
right.
I mean, years ago, there was somebody, and actually the first symposium we did, she spoke, but I am pretty sure she's moved out of the area.
Mhm.
Yeah. So I don't know either.
Sorry, I don't
Yeah.
know the answer.
We're sorry about that one.
Yeah.
Here, how are sessions with somebody like you conducted, and how often?
So
That one you can answer.
that one I can. So of course, the first session I always prefer to be in person. You know, since the pandemic and telehealth, and that certainly has left an option for remote treatment. But I do think an in-person evaluation, and as much in person as we can do, is invaluable. And then after that, depending on the diagnosis, I'll usually see, and especially even not depending on the diagnosis, I think it's important to establish a therapeutic relationship with someone so that you can really understand each other and understand what the questions are, and then how to navigate the disease or illness, and then so I usually meet every other week initially until that's established. We have a plan in place. We know what we're both doing, and we're making progress. And then as someone's gradually getting better, we spread out those visits. And I make myself available if there are any questions that come up. Things change at any time, and we've got lots of new avenues of communicating with your provider, like through the MyChart and all of that. But I think it's important to have, it's a hard enough illness to cope with and go through. You don't need the extra stress of not being able to get a hold of your provider. So we need to, know how each other works, and then respond to questions as quickly as possible. I think that's really important. So it depends on the person and what they need, but it'll be, in person every couple of weeks, and then as we get things going, it spreads out.
So I think you just gave this answer, but do you offer help outside of just prescribing more meds?
Yes, that's what I mean. Is I think that it's important to establish a therapeutic relationship first. It's not all about treating with medication. There are a lot of non-pharmacologic strategies that need to, and education that need to be reinforced, and support for dealing with a neurologic disease that has so many different symptoms and different categories of symptoms. So those questions come up all the time, and it might not be related to depression. It might be something else. So we need to know what that person is dealing with, and then direct them in the right avenue to get whatever that symptom is treated.
Where does the care partner come into all of this?
They're very important.
That's very important.
Great. I'm sorry I left that person out of the.
Yeah,
I've also liked after the initial evaluation, I always make an effort to reach out to whoever that care partner is, whether it's a spouse or a adult child or friend, so that, because that person knows you better than I do, and I'd like to have everybody, someone you trust as a patient, be able to weigh in on how they see things going. And then depending on what everybody needs and the treatment plan, I'll either see the patient first, and then at the end of the session have the care partner come in, or see everybody together, or half and half. It depends on whatever's going on. So absolutely very important.
And then here's one, I would appreciate hearing more about apathy.
Ah.
I don't know what more, but more.
Apathy is a really, well, there's a whole lecture I have on apathy. This was a short version
We'll come
today.
back. We'll do
I'll
another
come
one.
back. But I think that's probably, I don't know, Gwen, would you say that's the most, the least studied piece or the hardest to study? I don't know about that piece. It's hardest to identify. I find it even difficult myself. And so even just understanding enough about it, making sure that we have an eye on it, and how much is that underlying what else is going on too. So
yeah, I think that, I think in one of the challenges in terms of on the research side and also doing clinical trials is that, we have different measurement scales. And apathy is one example where there's a couple of different apathy scales. I think but to have a scale that's tailored to individuals with Parkinson's disease, that's been a bit challenging. And we have in one of our studies, we've used a specific scale for this that seems to work pretty well. And then the other issue is that it's the sort of in terms of apathy is is understanding the neurobiology and how, so we have apathy. There are individuals who have, for example, individuals later in life who have depression, and the depression will clear, and then they have persistent apathy. And the depression, and typically with, again, correct me, Becky, but if with antidepressants will treat kind of some of the depressive symptoms, but sometimes there's persistent apathy. And I think that so I think there's not really a good, and I can quote Dr. Kelly Mills, who's our director of movement disorders. We were talking at the MAP symposium, and he actually, he mentioned to me he was working on a review article, and he said, we really don't have good treatments for apathy. So, and then I wonder also if some of the behavioral interventions would, are there kind of tailored behavioral interventions for apathy? That might be something to kind of consider in terms of an area that would be great for treatment development.
Okay, another 2 questions in the chat. Can levodopa cause anxiety or depression?
So, well, lack of levodopa could certainly do that. That's part of the wearing off a period where when the dose is wearing off before your next dose, certainly you could notice some increased anxiety and actually lower mood, and actually some cognitive slowing, sort of all in that time frame. And as soon as your next dose kicks in, that usually resolves it. So that would improve. So, but in terms of causing anxiety, I don't think that would be, it's more the wearing off piece.
And another one says, what's your view on PWR?
I need more from PW.
It's basically it's exercise, I believe. PWR.
Parkinson's is okay.
Hold on a minute.
I guess we need to look that one.
All right, while I Google
if it has
that,
exercise in it, my view is positive.
while I Google that, which I should know it by heart, of course, but I don't.
Parkinson's wellness recovery, is that?
That's it. Thank you, Gwen.
I'm sorry, I don't know about that. Is that a structured program of?
I think so.
It sounds something like that. I guess I need to familiarize myself with that. But if it's a structured program of how to incorporate exercise, and I would hope I put a plug in for some relaxation or meditate, some space for that also, but I'm guessing, so I don't know.
Okay, so all right, the next question is, my husband has Parkinson's and recently had an additional diagnosis of Lewy body dementia. He sleeps 14 hours, evening, night, and morning, with an additional 2 hours after a light breakfast. Sometimes he's too sleepy to even eat. Is this a symptom of Lewy body or depression?
or medication. So Lewy body dementia, patients with Lewy body dementia do tend to be more sensitive to medication side effects, and also the actual disease itself can fluctuate. So in fact, that's part of the there's a fluctuation in level of alertness and sensorium. But if he's sleeping most of the time, all of the time, it makes you wonder, is there some other process, or medication, or that would certainly need some more, because there's usually a fluctuation to level of alertness with Lewy body.
Okay, any other questions? I don't see anything else on the chat, and that's all the questions I've got. Does anybody have anything else to add? Any more questions from anybody? No? Okay, I'm going to make a plea once again for everybody to please fill out the evaluation that you're going to get as soon as this is over. And I want to thank Becky and Gwen for coming this evening, and it really has been interesting. And I think we're going to have to do a second one in 2025, not now, but in 2025.
Yes, exactly. Great. No, that would be great. We really appreciate being
Wait a
invited
minute,
and
wait a
the great
minute, wait a
org-
minute.
Wait
Wait a minute, there's a question. Oh, thank you. Oh
Oh.
gosh, thank you.
Oh.
You're welcome. Wow, you're welcome. The first time I think somebody's ever said that. There we go. Okay, so and thank you for coming, and thank you for talking, and
It's a pleasure to be here.
it's only 8 o'clock, so
Yeah.
you can go have dinner if you haven't eaten yet.
Okay.
Okay,
Good.
thank you. Thank you. Good night,
Take care.
everybody. Good
Bye.
night.
Thank you so
Thanks.
much. Bye.
Thanks. Take
Bye.
care. Bye-bye.
Bye.